Soy el doctor Rosenberg Albores, presidente de la Sociedad Mexicana de Anestesiólogos Cardiotorácicos. Disculpen la facha, estoy trabajando en este momento, pero tenemos un gran compromiso el día de hoy. El día de hoy, el SMAC, iniciamos con una nueva modalidad, ustedes la van a ir descubriendo poco a poco. Empezamos con webinars con temas mensuales, esa es la intención. Vamos a tener un profesor internacional al inicio de mes y los otros 3 profesores nacionales también de mucho renombre, ¿no? Como hemos estado teniendo los webinars previos. En las redes van a irse enterando de los cambios que vamos a estar haciendo. Por lo pronto hoy tenemos ya un nuevo formato que resulta un poco más elegante y presentable para todos ustedes. Y bueno, sin quitar más tiempo, me enorgullece mucho presentar a la doctora Manchula Navaratnam. Ella es anestesióloga cardiovascular, anestesióloga pediátrica cardiovascular, está en Stanford, de la Universidad de Stanford, en San Francisco, y ella nos va a ayudar el día de hoy con el webinar de falla derecha perioperatoria. Es un honor de verdad que esté ella con nosotros. Es una gran profesora de la anestesiología pediátrica cardiovascular, con gran experiencia y bueno, el día de hoy va a colaborar con este tema. Vamos a continuar con el mismo formato de las sesiones previas. Las preguntas las dejamos para el final y la interacción con ella también. Iniciamos, por favor, con la plática. Gracias a todos por estar aquí.
Buenas tardes y gracias por invitarme a darles esta plática. Espero que les guste y que les sirva en su práctica. Today I'm going to talk about the perioperative management of patients with right ventricular dysfunction. We will briefly review the diverse etiology of RV dysfunction, discuss preoperative assessment and risk stratification of both adults and children, and lastly, discuss some strategies for successful perioperative management. I have no conflict of interest. With expanded therapies for pulmonary hypertension and congenital heart disease, and advanced technologies for mechanical support of the failing left ventricle, anesthesiologists are likely to encounter more adult and pediatric patients with right ventricular dysfunction presenting for both cardiac and non-cardiac surgery. There is increasing recognition that RV dysfunction is associated with poor clinical outcomes and is challenging to manage during the perioperative period. The broad definition of RV dysfunction is an abnormal RV structure or function. For the purpose of this talk, we will be focusing on RV systolic dysfunction. The etiologies of RV dysfunction are diverse, with acute, acute on chronic, and chronic subsets. Etiologies can be considered in 3 broad categories: RV pressure loading pathologies, RV volume loading pathologies, and impaired RV contractility. When considering the etiologies, it is important to remember the coupling between the right ventricle and the pulmonary vascular bed. Some examples of RV pressure loading pathologies include pulmonary hypertension, both pre-capillary, where the pulmonary capillary wedge is less than 15, and post-capillary, PH, with increased left atrial pressure from left-sided heart disease, such as aortic stenosis, mitral stenosis of left-sided diastolic dysfunction. Other examples of RV pressure loading pathologies include severe RV outflow tract obstruction or pulmonary stenosis or massive pulmonary embolism. Another cause which we have seen increased worldwide with the recent COVID-19 pandemic is ARDS or acute lung injury. Examples of RV volume loading pathologies include congenital heart disease or valvular pathologies such as Epstein's anomaly with tricuspid valve regurgitation, repaired tetralogy of Fallot with free PR, large left to right shunt such as large ASD. Lastly, conditions that cause impaired RV contractility include cardiomyopathies, ischemia, post-cardiotomy associated with cardiopulmonary bypass, single ventricle palliation where the right ventricle is systemic, and post-left ventricular assist device insertion. A thorough preoperative assessment is key to successful perioperative management. This includes a multimodal approach with trending of clinical symptoms and signs, hematological, hemodynamic, and imaging parameters. We will briefly discuss clinical features and some useful biomarkers and echo parameters, and integrate these for risk stratification of patients with right ventricular dysfunction. It is important to remember that patients with right ventricular dysfunction are often asymptomatic or may only have exertional symptoms. Symptoms and signs usually only manifest when right ventricular dysfunction has progressed enough to cause right heart failure. A definition of right heart failure is a clinical syndrome due to alteration of structure and/or function of the right heart circulatory system that leads to suboptimal delivery of blood flow, high or low to the pulmonary circulation, and/or elevated venous pressures at rest or with exercise. RV systolic dysfunction is an important cause of right heart failure. However, it is important to remember that right heart failure can be present in the absence of RV systolic dysfunction due to volume or pressure overload lesions. For example, severe tricuspid regurgitation or RV diastolic dysfunction. Symptoms and signs of early right heart failure, such as fatigue and exercise intolerance, may be non-specific and difficult to identify, especially in the pediatric population, who may be unable to verbalize abnormal sensations, or in the older adult with associated comorbidities. Clinical manifestations of more advanced right heart failure include dependent edema, elevated jugular venous pressure, tachypnea, cyanosis, hepatomegaly, S3 gallop, abdominal discomfort and bloating, ascites, pleural effusions, right upper quadrant pain from liver capsule stretch, and poor growth curves in children. Patients with severe right heart failure are frequently in a state of vasodilation, interstitial fluid leakage, systemic inflammation, and fever in the absence of infection. Hemodynamic studies have shown that venous congestion is more common than reduced cardiac output in children and adults with end-stage heart failure listed for heart transplant. There is a consistent relationship between elevated right atrial pressure and renal failure. Systemic venous congestion may be harder to recognize in children than adults because extracellular fluid may not accumulate in obvious places like ankles. In infants and young children, for example, dependent edema often manifests as periorbital edema. The JVP can be difficult to interpret in infants and children, and sudden weight gain from fluid overload may be attributed to normal somatic growth. End organ effects of chronic right heart failure are related to elevated central venous pressures with or without reduced cardiac output and include cardiorenal syndrome and cardiohepatic syndrome. Splanchnic venous congestion may also occur, leading to reduced gastrointestinal absorption and malnutrition. Preoperative lab studies may show elevated blood urea or creatinine or altered hepatic synthetic function, such as elevated prothrombin time. In chronic right heart failure, transaminases may be normal or minimally elevated, whereas in acute right heart failure, they are commonly high. Protein-losing enteropathy, or PLE, may be seen with decreased serum albumin and increased stool alpha-1 antitrypsin. Including plasma biomarkers to the preoperative assessment can help with risk stratification. Traditional biomarkers such as albumin and CRP are non-specific. However, hypoalbuminemia has been linked with adverse outcomes after cardiac and non-cardiac surgery, and CRP is an independent predictor of recurrent coronary events and thrombotic complications after surgery. Markers of cholestasis, such as elevated bilirubin, gamma-GT, and alkaline phosphatase, are independently associated with mortality in patients with heart failure. Elevated bilirubin has also been shown to be a risk factor for poor outcomes in patients with pulmonary hypertension. 3 contemporary biomarkers currently receiving attention are brain natriuretic peptide, or NT-proBNP, which signifies myocardial stretch, galactin-3, which signifies myocardial fibrosis, and high sensitivity troponin 3, which signifies myocardial injury. Expert consensus guidelines recommend measuring BNP or NT-proBNP for diagnosis and prognosis in left heart failure, and galactin-3 for added risk stratification. Elevated preoperative BNP has been shown to be a strong predictor of major adverse cardiac events after non-cardiac surgery. However, the role for biomarkers has not yet been established in right heart failure. Emerging studies have shown, however, that NT-proBNP may have prognostic value for right heart failure accompanying pulmonary hypertension and acute pulmonary embolism. TTE remains the first-line non-invasive imaging tool for preoperative assessment. Some useful parameters include estimation of RV afterload, such as pulmonary artery systolic pressure, variables of ventricular interdependency, such as analysis of septal curvature, RV systolic functional indices, such as tricuspid annular plane systolic excursion, TAPSE, or right ventricular fractional area change, and deformation indices, such as RV longitudinal strain and strain rate. The RV afterload, or RVSP, measurement uses peak velocity of the tricuspid regurgitation jet and the simplified Bernoulli equation to provide an estimate of the RVSP. The RVSP is also a surrogate measure of pulmonary artery systolic pressure, provided there is no RV outflow tract obstruction or pulmonary valve or pulmonary artery stenosis. It is important to get a good envelope of the TR jet for an accurate pressure measurement. As you can see here, the peak TR jet velocity is 4.6 meters per second, giving an estimated RVSP or PASP of 85 millimeters of mercury plus the right atrial pressure. The impact of one ventricle on the adjacent ventricle plays a key role in cardiac function. Ventricular-ventricular interactions are based on the arrangement in series of the circulation and common pericardium, the interventricular septum, and myocardial tracts. Variables of ventricular interdependency, such as analysis of septal curvature, are a useful part of assessment of the impact of RV enlargement on the left ventricular function. The eccentricity index in systole or diastole reflects compression of the LV by the pressure or volume-loaded RV, respectively. LV eccentricity index is the ratio of the LV vertical to horizontal diameter, measured from a short axis view of the LV at the mid-papillary level, for example, a parasternal short axis view on TTE. A D-shaped left ventricle and eccentricity index greater than 1 at N diastole reflects RV volume overload, whereas at N systole, it reflects RV pressure overload. In this figure, A is taken from a normal individual, and you can see the septal curvature is round, bulging into the right ventricle. The lateral dimension A and anterior-posterior dimension B are roughly equal, giving an eccentricity index of 1. However, figure B is taken from a patient with pulmonary hypertension, where the hypertensive right ventricle displaces the septum leftward, compressing the left ventricle in the anterior-posterior direction, giving an eccentricity index greater than 1. The RV to LV ratio can also be used, and qualitative assessment or eyeballing of the septal curvature can also be a useful tool. One useful measure of RV systolic function is the RV fractional area change, and this is a recommended parameter from the American Society of Echocardiography. RV fractional area change measures the fractional area difference between N diastole and N systole, and an RV fractional area change less than 25% signifies moderate to severe dysfunction. This measure has been shown to be a predictor of poor survival in pulmonary hypertension and heart failure. Another useful measure of RV systolic function is TAPSE. TAPSE is a measure of the lateral tricuspid annulus movement between end systole and end diastole. In the normal right ventricle, systolic function is maintained by mainly longitudinal shortening of the ventricle. TAPSE has evolved into one of the major clinical indicators of systolic RV function in pediatric and adult PH. In adults, normal TAPSE is anything greater than 17 millimeters, and TAPSE less than 14 millimeters has been shown to be a predictor of poor survival in adult pulmonary hypertension. Age and body surface area related reference values for TAPSE in the pediatric population have been published. One caveat with using TAPSE is that it does not account for radial contraction or segmental RV contraction. Radial systolic function is believed to play an important part in RV contractility in pulmonary hypertension and can be severely impaired in severe PH patients despite a normal measured TAPSE. Combining TAPSE with afterload parameters in children to obtain a TAPSE PASP ratio has recently been shown to be superior to TAPSE alone in differentiating patients with different NYHA functional class or modified Ross scores. Deformation indices, such as longitudinal strain and strain rate, are less load dependent and can reveal information about regional myocardial contraction. RV longitudinal strain is emerging in the adult population as an independent prognostic marker in pulmonary hypertension, an independent predictor of RV failure after LVAD implants, and a predictor of the need for high postoperative vasoactive support. In adults, severe RV dysfunction is defined as a strain greater than or equal to 15%. In children, normal age-related ranges are available. Tissue Doppler and speckle tracking technology is used to capture strain and strain rate. This graphical display demonstrates the strain values for the 6 segments listed above, and the color-coded graph corresponds to each segment. The dotted yellow curve shows the average strain. The greater the strain, the larger the downward deflection of the curve. The global strain, which is the average of all strain curves, measures to be 19.5% in this example. The yellow-green display shows the time to peak strain and can be used to derive dyssynchrony of cardiac motion. The more synchronous the heart is, then the less the difference in time to peak strain. Limitations of transthoracic echo include suboptimal image acquisition due to the complex right ventricle geometry and its retrosternal position. Echo-derived functional parameters are dependent on preload and angle of insonation, and significant intra-observer variability exists in their acquisition. Reliable volumetric data can currently only be achieved with 3D echo, not 2D echo. And cardiovascular MRI remains the gold standard for quantitative non-invasive measurement of RV volume, RV function, mass, blood flow, and tissue characterization, including children with congenital heart disease. However, in contrast to most adults, young children and those with psychomotor delay may be unable to tolerate a MRI without sedation or general anesthesia, and this can limit the feasibility of this investigation in hemodynamically marginal children. This MRI image here illustrates a severe Epstein's anomaly. Right ventricle dysfunction negatively impacts postoperative outcomes after cardiac surgery in adults and congenital heart disease patients. Recent adult studies have also shown that RVD is independently associated with major adverse cardiac events and a longer hospital stay in patients undergoing non-cardiac surgery. However, current preoperative risk assessment for non-cardiac surgery in adults still focus only on left heart dysfunction and do not incorporate markers of RV function. Contemporary publications addressing risk assessment scores for the pediatric population undergoing non-cardiac surgery also have not incorporated indices of RV function. One of the obstacles to incorporating RV function into risk stratification scores is the complexity, heterogeneity, and a lack of universal definition for RV dysfunction, which makes it difficult to compare or validate risk scores. The majority of published data, however, on clinical prediction scores for right ventricular dysfunction in both adults and children comes from two patient cohorts. One is RV dysfunction associated with pulmonary hypertension, and the second cohort is right ventricular dysfunction in LVAD-supported patients. Risk stratification scores from global adult pH registries have identified 6 consistent high-yield variables that indicate deteriorating RV function. And these include a 6-minute walk test, the WHO functional classification, NT-proBNP or BNP, cardiac index, right atrial pressure, and mixed venous oxygen saturation. However, the majority of adult scoring systems do not incorporate age, underlying cause of pulmonary arterial hypertension, comorbidities, or echocardiographic or MRI parameters. The majority of published data on pediatric PH patients undergoing non-cardiac surgery, including cardiac catheterization, comes from retrospective single-center studies. And variables that identify high-risk pediatric PH patients include WHO functional class 3 or 4, clinical signs of right heart failure, syncope, a mean pulmonary artery pressure to mean systolic artery pressure greater than 3/4, RV systolic dysfunction, a right atrial pressure greater than 15, NT-proBNP, elevated NT-proBNP, TAPSE, age less than 2 years, and increased complexity or duration of anesthesia or surgery. Although these variables may serve as a guide for the risk of adverse perioperative events and RV failure, none have been formally validated in the perioperative arena. Additionally, the impact of congenital syndromes such as Alagille syndrome or Williams syndrome have yet to be accounted for. The European Pediatric Pulmonary Vascular Disease Network has developed a novel pediatric pH risk score based on variables defining a low and high risk group. Here you can see that variables in the high risk group include clinical signs of RV failure, syncope, symptom progression, elevated BNP, echo parameters, and invasive hemodynamics. The intermediate group still remains poorly defined. Prospective validation of this novel risk score has commenced in children treated with off-label pH-targeted medication. Experts have suggested that the degree of RV adaptation in pulmonary hypertension may be a more accurate predictor of outcomes rather than isolated measurements of PA pressure in both the adult and pediatric PH population. RV adaptation in pulmonary hypertension initially involves coupling of the right ventricle to the high arterial load, and it is maintained by increasing contractility and wall thickness, followed by RV dilation, and finally RV uncoupling. In pulmonary hypertension, when RV to PA coupling is still present, volumetric data such as right ventricle end diastolic volume, right ventricle end systolic volume, and stroke volume may provide important prognostic information, but this needs further validation from large-scale studies. Emerging studies have also recommended the ratio of TAPSE to PASP as a reflection of the extent of ventricular arterial uncoupling, since TAPSE indicates RV contractile function and PASP a marker of RV afterload. Approximately 20 to 30% of patients, both adults and kids, get RV dysfunction after LVAD insertion. Currently, there is no consistent way to predict those patients getting LVAD implantation who will develop post-op RVD. Clinical prediction scores of right heart failure after LVAD implant includes parameters such as pre-implant age, vital signs, invasive hemodynamic metrics, echo parameters such as TAPSE and TAPSE RV-EDV, mechanical ventilation, creatinine, and total bilirubin. These scores only have modest performance in validation cohorts and currently do not account for the heterogeneity of population studied, and also do not account for dynamic intraoperative factors that increase pulmonary vascular resistance and precipitate acute right heart dysfunction, such as blood product transfusion, hypoxemia, acidosis, positive pressure ventilation, RV-LVAD interactions, and changes in RV volume loading and geometry with LVAD implantation. Emerging studies have shown, however, that RV longitudinal strain is a strong independent predictor of RV failure, and there's also been a lot of recent interest in pulmonary artery pulsatility index as a predictor of RV dysfunction following LVAD implant. This table summarizes some of the preoperative indicators of RV dysfunction, which should alert you to high-risk patients, and includes some of the symptoms and signs we discussed: serum markers, ECG changes, and some important echo parameters. Multidisciplinary discussions are vital for high-risk patients in determining the risks and benefits of the procedure specific to the individual patient and determining optimal timing for non-urgent surgery. Discussion includes adequate preoperative optimization, planning postoperative care, and discussing feasible exit strategies should complications occur. Examples of optimization include preoperative initiation of pulmonary vasodilators in untreated patients with PH, optimizing diuretic therapy, or commencing inodilators such as milrinone or levosimendan in patients with significant venous congestion. Some medications may need to be withheld prior to general anesthesia. For example, at my institute, we stop all ACE inhibitors 24 hours prior to surgery because of associated intraoperative hypotension, but we do continue all beta blockers and pulmonary vasodilators. There is no ideal anesthetic agent, and a variety of balanced multimodal techniques have been described in the literature. When we formulate perioperative strategies, we should consider the right ventricle as part of a cardiopulmonary unit and think about 4 main areas and the factors that affect them. This includes factors that affect right ventricle to pulmonary artery coupling, VQ matching, right atrium to right ventricle interactions, and right ventricle to left ventricle interactions. Decreasing RV afterload while maintaining RV preload, RV contractility, and RV perfusion is an important goal for these patients. In some instances, spontaneous ventilation can be maintained and is usually preferred, taking care to avoid factors that increase pulmonary vascular resistance, such as hypoventilation, hypoxia, hypercarbia, atelectasis, airway obstruction, and respiratory acidosis. When positive pressure ventilation is initiated, the goal is to prevent mechanical obstruction to pulmonary blood flow and a dangerous increase in RV afterload and reduction in preload during the inspiratory phase. Ventilatory parameters such as inspiratory to expiratory ratios, tidal volume, respiratory rate, and positive end expiratory pressure should be optimized to generate the lowest possible mean airway pressure compatible with the desired lung recruitment, minute ventilation, and gas exchange. Some patients may benefit from peri-intubation pulmonary vasodilators, such as inhaled nitric oxide, to mitigate any increases in PVR associated with positive pressure ventilation. It is also important to maintain coronary myocardial perfusion pressure and avoid the vicious cycle of RV hypotension and ischemia. Any systemic hypotension should be aggressively treated with judicious use of fluids and vasoactive medication to avoid the downward spiral of hypotension and RV ischemia. Some patients may need pre-induction inotropes, such as epinephrine, dopamine, or dobutamine. Inotropes such as epinephrine or dobutamine will increase RV contractility, but may induce tachycardia, which may in turn impair diastolic filling and coronary perfusion. Vasopressor therapy, such as norepinephrine, vasopressin, or terlipressin, may be indicated to increase the SVR, reduce leftward septal shift, and improve tissue perfusion, including coronary myocardial blood supply. Vasopressin has a theoretical advantage of being a selective systemic vasopressor and is not believed to increase PVR as opposed to norepinephrine and epinephrine, which can increase PVR at high doses. Inodilators such as milrinone or the calcium sensitizer levosimendan may be useful once hemodynamics have stabilized or as part of pre-optimization, but they are not first-line therapy in the setting of systemic hypotension. Maintaining sinus rhythm, atrial contraction, and AV node synchrony is also important. Tachyarrhythmia should be avoided, and some tachyarrhythmias which are seen in RV dysfunction include sinus tachycardia, atrial fibrillation, and atrial flutter. Bradyarrhythmias associated with RV dysfunction usually signify a preterminal event or severe ischemia of the conduction system and should be treated immediately. TTE monitoring can also be useful during anesthesia induction, especially in young infants and children if pre-induction arterial lines cannot be placed. TTE can be used to monitor RV dilation, interventricular septum position, and LV function, especially during the transition from spontaneous to positive pressure ventilation. Focused transthoracic or transesophageal echo is an important intraoperative diagnostic tool for any hemodynamically unstable patient. Echo indicators for perioperative RV failure include signs of RV dilation, for example, systolic or diastolic D-shaping or moderate to severe TR, signs of impaired RV systolic function, such as TAPSE or RV fractional area change, and signs of elevated RV preload, such as plethoric IVC. Acquisition of quantitative parameters can be time-consuming and technically challenging in the operating room, and some experts have suggested that physicians should also be familiar with qualitative echo assessment of RV dilation and function. However, there may be a steep learning curve associated with acquiring this skill set. After patients leave the operating room, they remain at risk for adverse events and require vigilant monitoring of their oxygenation, ventilation, and perfusion pressure. Optimizing post-operative RV function involves balancing fluid titration with fluid restriction, optimizing heart rate and rhythm, maintaining normal acid-base status, avoiding positive pressure ventilation and hypoxia, and ensuring adequate analgesia, temperature management, and early use of pulmonary vasodilators and inotropes. I'm just going to briefly show you two cases which recently occurred at our hospital. The first was a 9-year-old 30-kilo child with unrepaired Epstein's anomaly and SVT, and he presented as an outpatient for cardiac catheterization study and EP SVT ablation. He had been asymptomatic up until 3 months ago when he developed SVT refractory to antiarrhythmics, worsening exercise tolerance, decreased appetite, and intermittent edema of the face, abdomen, and extremities. And his pre-op med was just atenolol. And here you can see the TTE showing severe Epstein's anomaly with extremely severe right atrial dilation and free tricuspid regurgitation with no coaptation of the tricuspid valve. He also had moderate pulmonary insufficiency and a ventricular septum bowing into the left ventricle in diastole, consistent with RV volume overload. Although he had only mildly diminished LV systolic function, there's essentially no RV cavity with limited contractility of the RV outflow tract, suggesting a physiology similar to a Fontan. This patient had progressive hypotension following anesthesia, induction, intubation, and positive pressure ventilation, despite epinephrine, and he was cannulated onto VA ECMO through the groin in the cath lab, and then went to the operating room 5 days later for a paracorporeal RVAD insertion. He's currently doing well and waiting on the wait list for heart transplant. The second case is a 4-month-old, 5.4 kilo term infant who had a neonatal repair of tetralogy of Fallot with pulmonary atresia and a confluent PA fed by a PDA. And this baby was transferred from an outside hospital with severe conduit stenosis and RV failure. She came with an arterial line and a double lumen PICC line in situ and was on milrinone of 0.5 mics per kilo per minute and was spontaneously ventilating on oxygen through a nasal cannula at 1 liter per minute. Her mixed venous saturation was 40% and she had a BNP of 60,000. And here you can see her transthoracic echo showing a severely dilated right atrium, severe tricuspid regurgitation with multiple jets, and a severely dilated right ventricle with severely depressed function. She also had a PFO with bidirectional shunting and mild MR. And you can see here that the estimated RV systolic pressure was roughly 80 millimeters of mercury plus right atrial pressure. And again, you see a short axis view with a severely dilated right ventricle and severely depressed function, and a flattened ventricular septum throughout the cardiac cycle compressing the left ventricle. And this patient had reached the stage of RV to PA uncoupling. So this patient was commenced on epinephrine in the operating room prior to anesthesia induction and had a slow anesthesia induction with fentanyl, ketamine, and rocuronium. She received gentle positive pressure ventilation prior to intubation, and the anesthesia induction was uneventful, and she went on to have a successful redo sternotomy and repair of her conduit stenosis, and is currently doing well on the intensive care unit. So it is important to remember that although perioperative management of patients with right ventricular dysfunction can be challenging, one can achieve successful outcomes. However, successful outcomes do require careful and meticulous planning, close communication, and a multidisciplinary approach. Thank you. With right ventricular dysfunction can be challenging. One can achieve successful outcomes. However, successful outcomes do require careful and meticulous planning, close communication.
Muchas gracias a todos por conectarse a esta reunión. No sé si tengan alguna pregunta para nuestra ponente, una exposición extraordinaria. Thank you very much, Manchula. It's extraordinary, like always. We're going to the answers for the people. No sé si tengan alguna pregunta para la doctora. Pueden escribirla a través del Facebook y pues es el momento de decir que de aquí la tenemos y es momento para que nos apoye a contestar nuestras dudas o preguntas que tengamos. No sé si alguien tenga alguna pregunta, si no para pues ya dar por finalizado este webinar. I think everything was very clear, Manchula. Anybody has questions? But if anybody asks something, I will tell you.
Okay.
Aquí, ya. Ya tenemos un par de preguntas. Pamela Domínguez pregunta que we know echo is becoming the main monitoring strategy. la pregunta de Pamela Domínguez. Pamela Domínguez said, we know echo is becoming the main monetary strategy. Do you think so?
You mean preoperative or intraop or postop?
I think transoperative.
Yes. Yes, we use, for cardiac surgery, obviously, transesophageal echo. But for non-cardiac surgery, now there's a big push towards doing focused transthoracic echo as well to help monitor these high-risk patients.
And what do you think about Swan guns? Do you use in these patients?
So I work in the pediatric hospital. So for the cardiac surgeries, we don't use Swan GANs, but we do a lot of direct intracardiac monitoring, especially if they've had, valve replacements, etc. But I do feel in the adult population, there is still a place for Swan GANs and pulmonary artery catheterization. Of course, the intensive care unit has to be trained in using PA catheters, and often that can be a problem in pediatric units as well.
Oh, thank you. Another question. Laura asked, which catecholamine do you prefer to use with milrinone?
So it depends. That's a good question. I think there's a number of factors that will affect it, what is available to you and what your institute's preference is. And also depends on how sick the patient is. If I feel a patient is very sick, for example, the child with the second case, the infant that came in acute right heart failure who was on milrinone, we started epinephrine because the RV really wasn't contracting much at all, and I wanted something before the induction. So if I feel the child is very sick, I would start epinephrine. If I feel the child is not so sick, I would start dopamine. But some institutes don't use dopamine; they prefer epinephrine. Some institutes prefer dobutamine. So some of it is also institutional driven as well.
Okay, even in newborn.
In newborns, we use a lot of dopamine as well in our institute. Yeah.
Okay.
Yeah.
Okay. And is it useful, the transthoracic echocardiography in this patient, monitoring them?
You mean in the non-cardiac rooms?
Yes.
Yes, I believe so. We've done quite a few anesthesia inductions with transthoracic echo. And I think looking at that septum position and seeing how much it's bowing and compressing the left ventricle can really give you an idea of if the RV is getting dilated or not. Obviously, if you have arterial pressure monitoring, that's great. But for a lot of infants, we're not able to place invasive arterial pressure monitoring until they're asleep. So I think in those cases, the TTE really helps.
Okay. Another question. You have a lot of questions.
Okay.
Wait a minute. Here is. What do you think about the use of levosimendan in right ventricular dysfunction after cardiac surgery?
Yeah. So I know, again, this is an institute preference as well. So I know in Europe, they're very keen on levosimendan as an inodilator. In my institute, we don't use levosimendan, we use milrinone as the first line inodilator. So I personally have not had a lot of experience with levosimendan, but talking to many of my colleagues in Europe, they use it a lot. I'm not sure what you have access to in Mexico or what you use there. I would be interested to know.
In my institution, we use levosimendan, but we use more for left ventricular dysfunction. And for right ventricular dysfunction, we usually use more milrinone. Mm-hmm. Yes, but we have levosimendan available, I think, in all Mexico. Yeah. Yes. Another question, Lourdes Pellecer. Excellent presentation. Thank you very much, Manchula. There are some studies with a low population that expose the use of vasopressin with possible pulmonary vasodilator action. What have you observed in LPCH patients?
Yeah, so I think Laura knows that one of the few studies came from our institute. In a small group of patients, one of my colleagues looked at the effect of vasopressin in pulmonary H patients and found that it decreases the PVR, whereas things like phenylephrine, epinephrine can produce an increase in PVR. So we, as an institute, use vasopressin selectively for SVR issues over other things. Yeah. But I know a lot of institutes don't have access to vasopressin.
Okay.
We've also started looking at vasopressin in failing Fontans who come in a vasodilatory state, and we feel that that's been useful to get them through perioperative periods as well. And we use it a lot in our liver transplant patients as well, who come in this kind of vasodilated acute liver shock state. Do you have access to it in Mexico?
Yes, we have access to vasopressin, yes.
Yeah, and do you use it much?
We use, in particular, I use with the Fontan and some kind of the same way that you use, I think.
Yeah.
Another question, Alejandro Cornejo. Of the red flags in the preoperative assessment, which one is the most important to look for?
That's a good question.
Yes,
you know, I think one of the things that it's important to do when you do the preoperative assessment is disease progression. So if there's any changes in symptoms or signs, that is to me a red flag. So a child, for example, the Epstein's case I presented to you, 3 months before he came for his EP study, he was fine. There were no symptoms. But in those 3 months, he was starting to get decreased exercise tolerance, edema, and those that had not been appreciated by his primary care physician until, you know, he presented on that day for the SVT ablation. So it's hard to pinpoint one red flag, and often you have to take them as a combination. But I think it's important, you know, we do rely a lot on echo. And the other thing I would say about echo for RV failure is it's important to look at the images. Sometimes the functional or the parameters don't really reflect the images. So it's really important when you do a preoperative assessment to pull up the TTE and get used to looking at the images, what we call eyeballing. Because the more images you look at, the more you'll get used to seeing, oh, this RV really looks terrible compared to that RV. Even though the TAPC, the RV fractional area change, they may not be that much numeric data, but there's a lot of value in getting used to looking at images. And so that would be my advice to you as well with echo interpretation. Sometimes the numbers don't always reflect the image. Yeah.
The qualitative evaluation. No?
Yes, exactly. Yeah.
Dani Escamilla, is there any benefit from using of BIAC in right ventricular failure in waning of bypass?
Use of what, sorry?
Is there any benefit for use BIAC in right ventricular failure when you are in waning bypass?
BIAC, I'm not sure what you mean.
Okay, yeah, yes. Contrapulsation balloon.
Oh, intra-aortic
contrapulsation balloon.
Yeah, you mean on the right side?
Yes, on the right.
Percutaneous RVAD?
Yes, what do you think when you are in the waning of bypass?
Yes.
And you have problems and you know that it's about for right ventricular dysfunction, what do you think to use intra-aortic contrapulsation balloon?
Yeah, so do you mean the on the right side or on the left side?
No, on the left side, the intra-aortic. Yeah. But some people say that you can benefit the coronary circulation when you use the balloon, and then you can benefit the right ventricle could benefit it.
I have not had experience with that. you still have to support the right ventricle. You know, I have a lot of experience with LVAD insertions, and when we separate from bypass with a left ventricle assist device, we still have to protect and augment the right ventricle. So, you know, having left ventricle support doesn't mean you still have to have a good working or a supported right ventricle to get blood through to the left side. So what we have seen when we separate with LVAD is we're very aggressive in supporting the right ventricle. So for all our LVADs, for biventricular LVADs, we come off with dopamine, epinephrine, milrinone, and inhaled nitric oxide for all patients separating with an LVAD, so that we can aggressively support that right ventricle. So I haven't had experience with the intra-aortic balloon pump separating as a support for that right ventricle, so I couldn't comment on that.
Okay. The next question, have you ever had problems with using milrinone like atrial fibrillation or ventricular tachycardia?
No, I haven't, but I would say that, you know, with milrinone, when you're using a milrinone for acute right heart failure, you have to be careful about systemic hypotension. So milrinone is not a first-line therapy if somebody is hypotensive. So, and if you're getting ventricular fibrillation or atrial fibrillation, that's usually a sign of ischemia, and usually that your coronary perfusion pressure is not adequate. So it may be that it's not the milrinone itself, but it could be associated hypotension. So you usually have to support with something else like dopamine or epinephrine.
Okay, another question. Wait a minute. When do you recommend ECMO therapy in right ventricular heart failure?
Yeah, so for ECMO, yeah, so it depends on, you know, the situation that you're...
I think he wants to refer the precise moment when you decide to use the ECMO.
ECMO.
When you have a right ventricular dysfunction and you said, I will need ECMO.
Yeah, so, you know, if you look at that kid with Epstein's, if you look at that echo, you know that there's really no RV, functional contractile RV in that child. So you know as soon as you do positive pressure ventilation, the chances of ECMO are very high. So that's why the multidisciplinary preoperative discussion is really important, because it helps to identify those patients who are extremely high risk of ECMO, and then to have people available to put them on ECMO quickly without, you know, proceeding to ECPR. So those discussions are very important. You know, right ventricular dysfunction as an anesthesiologist, for me, it always makes me far more nervous than when I induce somebody with isolated left ventricular dysfunction. Because usually when you institute positive pressure ventilation for a failing left ventricle, you offload the left ventricle. But for a failing right ventricle, positive pressure ventilation can increase the RV afterload. So everything that we do as anesthesiologists potentially can hurt the right ventricle. So that's why I would say if you're faced with somebody with right ventricle dysfunction or severe right heart failure, you have to be quite concerned.
Okay. Rosenberg asked, what do you think about the use of intratracheal milrinone when you have a right ventricle, acute right ventricle failure?
I have no experience with intratracheal milrinone. I'm not sure, I don't know about the absorption, but I would just say again, with milrinone for acute right heart failure, you have to be careful about the systemic hypotension. So I'm not sure if intratracheal administration causes less systemic hypotension than intravenous. I'm not sure of that. I don't know of any studies that have looked at that. I'm not sure if Dr. Rosenberg knows more about that. But the only thing I would say is, you know, you have to be careful about starting milrinone in causing systemic hypotension if somebody is acutely unwell. So to make sure that you have something else that's going to maintain your perfusion pressure.
Okay. Octavio Morales asked, what kind of cardioplegic solution do you use in your institution?
Oh, for cross-clamping and things?
Yes, for cross-clamping.
Yeah, we use Del Nido, cardioplegia, yeah.
And do you think it's related with right ventricular dysfunction, the use of some kind of cardioplegia?
We haven't seen that. We changed to Del Nido a few years ago. That you do need to make sure that they have enough calcium on board when you separate with the Del Nido solution, but haven't seen that the solution itself causes any issues.
Okay, another question, Rafael Lima. On isolated right ventricular dysfunction with left ventricular function preserved, do you prefer ventricular assistance ECMO or just support or only support the right ventricular?
Sorry, can you repeat that again?
Okay. When you have right ventricular dysfunction in the context of left ventricular function preserved, do you prefer use ventricular assistance, ECMO, or just support the right ventricular?
So again, it depends on the situation, you know. Okay. So if the patient is in the intensive care unit, has some other illness, or if they're coming for cardiac surgery and they're separating, or if they're going for non-cardiac surgery, and it, you know, so it really depends on the situation.
Yes. Rosenberg said that he thinks that I don't know, maybe he read that intratracheal you can use to prevent the systemic effects of the milrinone.
Okay.
I don't know which dose do you use for milrinone?
We start between 0.25 mics per kilo per minute and 0.5 mics per kilo per minute. Yeah.
And do you use a loading?
We don't load. We used to load a long time ago, but we found that there's too many uncertainties with the load. Yeah.
Okay, I think it's. I don't know. No sé si tengan más preguntas. Ahora sí que ya sé. No hay más preguntas. Bueno, pues muchas gracias a todos por haber estado en este seminario web. Creo que fue muy constructivo. La interacción fue muy buena. En nombre de Rosenberg, como él comentó, ya estaremos dando los nuevos formatos para estas sesiones web que daremos todos los lunes. Contaremos con una vez al mes, el primer lunes de cada mes, con un ponente de talla internacional. Nos da mucho gusto que esta vez nos haya acompañado Manchula. Thank you very much, Manchu. It was a great pleasure and it was an excellent presentation. We appreciate it a lot. Then again, thank you very much in the name of Rosenberg that he is working and in the name of all the Mexican cardiovascular anesthesiologists. I think it was an excellent presentation.
Thank you. It was an honor for me to be part of this. So I appreciate you inviting me.
Thank you very much. See you soon, Manchula.
Okay. Bye. Thank you.